Hello, everyone. Welcome. Good morning and good afternoon, depending on where you are. Welcome to the fourth day of the Effective Ways to Increase Vaccination Rates Symposium at Columbia University and University of the Witwatersrand. I would just like to begin with a quick Zoom note that we do welcome audience questions today. Our speakers will have a chance to answer audience questions in the later half of this session. Please ask your questions by typing them into the question and answer box. There's a button at the bottom of your Zoom screen that says Q&A with 2 speech bubbles. If you click open that button, you'll have space to type in questions that we can then pose to the panelists. You will also be able to see questions that other attendees have asked, and you'll be able to upvote the questions that you would like to see answered. We will also be putting the full bios of all of our speakers today linked into the chat box. So please do learn more about our speakers if you're interested. With that, I would like to welcome Dr. Wilmot James, who is the symposium convener for the week and also our moderator today. Dr. James is a senior research scholar at the Institute for Social and Economic Research and Policy at Columbia University, where he also chairs our Center for Pandemic Research. Dr. James, thank you for leading us through today, and over to you.
Thank you very much, Harlow. Thank you very much to all our speakers and panelists and to our attendees. You're most welcome to today's session. And this session will focus on essentially 2 concepts and qualities, trust and social norms. When we speak about social norms, we talk about conventions about what's desirable. When we speak about trust, it's quite a difficult quality, but when I think about trust, I think about people who consistently keep their promises. Those are the people you trust. And if the trust is in the promise of healing, when patients go to physicians, they accept the recommendations, and actually it's an instruction to take therapies because they trust the expert knowledge of the physician that they meet. So those are the 2 things we want to talk today about in relation to trust and social norms in relation to vaccines. And we are talking about it because we are greatly concerned that even though vaccines are becoming increasingly available in many parts of the world, people are hesitating to take them, or they're resistant to taking them, or they object to taking them, or they're simply uncertain. And we are talking largely about the uncertain spectrum. Individuals who are not quite sure, who don't have enough information, or are yearning for more information, and are really wanting to hear that others around them are making decisions and taking a cue from them in terms of taking vaccines and therefore driving up vaccine take-up overall, which is our pathway to better manage the pandemic. So we have some wonderful speakers with us today to take us through the issues, starting off with Dr. Tariro Makadzange, who is an infectious diseases specialist and a viral vaccine immunologist. She earned her BA from Smith College, an MD from Harvard, and a DPhil from Oxford University. Her research is focused on HIV immunology, and she's also managed clinical trials and has worked in the area of implementation science. So she will start off. She will be followed by Janan Dietrich, and Dr. Janan Dietrich, and I'll introduce her when she responds. She will be followed by Dr. Hassan Mohamed. Dr. Janan Dietrich is, I apologize, at the University of the Witwatersrand in Johannesburg. And she will be followed by Dr. Hassan Mohamed, who is with the Western Cape Health Department as the Chief Vaccine Advisor to that department. And then finally by Dr. Jonathan Strysko from the Children's Hospital of Philadelphia, otherwise known as CHOP by its acronym, and the Botswana-Univ Pennsylvania partnership. So with many thanks to you, Dr. Makadzange, for leading us through this really quite important issue of trusted voices. This is the title of today's session. Trusted voices must be used to relay social norms when it comes to vaccines. So over to you, Dr. Makadzange.
Thank you. Thank you so much, Dr. James. It's really a pleasure to be here. I'm going to go ahead and share my screen and share a few slides with you. Can everyone see my screen?
Yes, we can.
Perfect. Great. Well, thank you. So today I'm just going to talk a bit about trusted voices that need to be used to relay social norms. I'm, as Dr. James indicated, a physician scientist, a vaccinologist, and founder of Charles River Medical Group, a contract research organization in Africa. So my talk today will really just touch on a few key issues and really look forward to the comments and further discussion from my colleagues. But I wanted to give a little bit of a context, so the historical context of vaccine hesitancy, touch on hesitancy itself briefly, and then really focus on communication and trusted voices, and end with a brief discussion on where we are with vaccines, particularly in Africa. The historic context really reminds us that vaccine hesitancy, or the challenges of ruling out vaccines, is not something new. It's something that's as old as vaccines themselves. So Edward Jenner introduced in Western societies the idea of variolation, so injecting a small amount of cowpox to prevent smallpox, and vaccine hesitancy was high. This was not a novel technique. It was being used in African and Asian societies for a long time, but its introduction in a new society led to a lot of fear, a lot of skepticism, some of it based on lack of information. People didn't understand the science, the pathophysiology of how it worked. As is now, ideologies around personal liberties were important. Are you interfering with my personal rights? There was a mistrust of the establishment. So in the 18th century, there wasn't much trust of the healthcare system, particularly if you were poor and of a low socioeconomic class. And all of a sudden, health authorities were touting this as of benefit to you. So there was understandably quite a lot of mistrust and moral panic based on religion, culture. How can you introduce something from a cow into humans? And so, as you can see from this cartoon, there was a lot of societal fear around the effects of this new vaccine and new innovation. And it wasn't until the 19th century, as governments started to put in laws and mandates around vaccination, that we started to see a significant uptick in smallpox vaccination. But I think this just reminds us that this is not new. It's a phenomenon that has been with us throughout history, both remote history as well as more present history. So what is vaccine hesitancy? So hesitancy is really a delay in acceptance or refusal of vaccines, despite the availability. And that's really important because it's difficult to talk about hesitancy when there isn't availability. Confidence is a slightly different factor and really based on a number of factors, including safety concerns and trust in regulatory and health delivery systems. And just a reminder, as we talk about communication and trusted voices, is to really think about what hesitancy is and recognize that it is a continuum from those who are early adopters, accept everything, really don't question vaccines much, all the way through to those who refuse all vaccines. And there's a large group of people in between who accept some vaccines, but not all, may delay and refuse some, or refuse but are unsure. And it's really important in communicating to really think about which target group to focus your attention on. Those that refuse all in the United States, for example, are a relatively small percentage, less than 1%, and it might be difficult to gain sufficient traction in that group. And it may make sense to really focus on other groups where one could potentially make a significant difference. And so what are the determinants of hesitancy? And again, they sort of lead into this discussion on communication and trusted voices. And this is a nice framework developed by the WHO around the 3 C's. So confidence in vaccines is really important, the confidence in the efficacy and safety, as well as the reliability and competence of the healthcare systems and healthcare professionals, and trust in the policy decision-making. I think many can recall just before the last elections, the 2020 elections in the United States, there was a lot of concern as to whether or not there'd be political interference with the approval of vaccines. And it's really important to communicate to communities and populations that there isn't such interference, and to gain the required confidence in the regulatory approval processes as well as guideline development. The next issue is convenience. So are vaccines available, and are they accessible? Do you need to walk kilometers to get to a vaccine? Do you need to give up work and other activities to be able to do that? Are vaccines affordable? Is there sufficient literacy in the population around the vaccines themselves, their safety, efficacy, and really addressing the issues that communities may have? But also, what is the service delivery, the quality and convenience? The last issue is complacency, which can be a double-edged sword and may be a result of highly effective vaccination strategies. So changing the perceived risk of a disease, and we've seen this with measles in some communities where there has become complacency around vaccination, the perceived perception that the risk of disease is low, and sometimes fueling some of that hesitancy, and unfortunately subsequently leading to outbreaks, as we saw in the US in 2015 with an outbreak of measles in Orange County, California. So many factors do drive hesitancy, and I'll touch a bit on these as well as we talk about communication and trusted voices. In broad strokes, context is really important, because context shapes communication, whether it's in traditional media forums or social media forums. Religion, politics, leadership are all critical components. Then there are individual as well as group factors that drive hesitancy, things that are related to perceived risk, attitudes, belief, and social norms. And then there are vaccine-specific factors that we'll touch on briefly. But the context really does matter in every situation. The local context and environment is really important in driving social norms and in communicating and building trust around vaccines. The historic context is important, and that may include prior history and experience with vaccines and other therapeutics in general. Trust in the immunization program, gatekeepers, as well as trust in the industry that is producing that therapeutic or that vaccine. Cultural factors are also incredibly important, and communication strategies can make or break vaccine efforts. Media, influential leaders, religion, culture, and gender. We do know that there are differential rates of immunization based on gender, and those can vary from community to community. Economic factors are important, and these not only include access, but also the socioeconomic consequences of disease. And in the context of COVID, this has been quite important with the lockdowns and the economic consequences of those public health mitigation efforts. The politics, the policies, and the trust in the decision-making and policy formulation also can be key determinants of hesitancy within a community. The individual and group influences can include personal experiences, not only with prior vaccination, but with health system delivery in general, beliefs and attitudes around health promotion, prevention, vaccines, and decision-making around risk of disease versus the benefit of vaccines. And many of those can spill over into group influences with your family, peer group, and community, really shaping some of the social norms around vaccination and health-seeking behavior, and determining many of the beliefs and attitudes towards health and prevention. And then lastly, the vaccine-specific issues, and these are really important to keep in mind, and are related to the individual disease, and can be based on epidemiology or scientific evidence driving risk-benefit. So, for example, young people might conceive themselves or perceive themselves as being low risk of COVID, and go off onto spring break to have huge parties and end up with an infection rate. So how do people perceive their risk for a disease relative to the rest of the population? Introduction of new technologies can really drive vaccine hesitancy, and it could be a new platform or even an old vaccine with a new formulation can be part of an important determinant of hesitancy. A route of administration and vaccination schedule are also incredibly important. And we saw this with the Japanese encephalitis virus vaccine introduction in India, where older formulations had very complex vaccination schedules, and more modern formulations with simpler two-dose schedules, and combined with some epidemiologic changes, really became an important driver for enhancing and increasing vaccine uptake. So those individual vaccine schedule factors can become very important. In addition, the supply chain reliability, the logistics, can the vaccine be included in with the rest of the vaccines, or does it need a separate handling system? Costs and strength of the recommendations for vaccination, as well as the attitude of healthcare professionals around vaccination. So now to touch on the communication and trusted voices component. So we've talked about the history and what vaccine hesitancy is, and some of the determinants of that. And what has been evident throughout the history of vaccines, and particularly in the modern era, is that communication is a really important tool. And clear communication, a clear communication strategy is very important. The absence or the lack of a good communications strategy, or an inadequate and inconsistent strategy, can be an important driver of hesitancy. And this is an important thing to note, because we often dedicate resources or think about things like manufacturing, distribution, and fail to really focus on communication, which is a key factor for vaccine uptake. And with COVID, the WHO, CDC, and other groups have recognized that this is really important component, and have developed some nice strategies and tools to facilitate effective communication. But this can be very challenging, particularly in the setting of a pandemic, where you're almost building a plane while you're flying it. So you're generating new data, new information is coming through very rapidly and in real time, and that can lead to inconsistencies. And we've seen that most recently, where earlier on in August, the Biden administration announced that booster shots would be available for all, in part driven by some of the data from Israel. However, they did indicate that they wanted to get expert data first to finalize the decision. And the expert panel, just as most scientific panels, had mixed reviews and landed on recommending vaccination for select groups of individuals. And this was further refined by the CDC directorate. But it meant that for the population who doesn't understand, who may not understand the nuances of scientific debate, data review, building a consensus and recommendations, it left a confusing message around boosting, who needs it, why do they need it, how should they get it, etc. And so it is really important as communicators on health to try and have very clear and crisp communications, but also pointing out that it is very challenging, particularly in the current scenario where you have data evolving pretty rapidly. So most of our communication strategies have really focused on things like disease prevention. And this has been particularly evident with COVID, where we saw massive economic and socioeconomic consequences of the lockdown. So much of the communication focus has been about how we can prevent disease and our responsibility to society. And some of that has been couched as societal responsibility to ensure herd immunity. And this has been interesting because this has also evolved as we've learned more information and more data. I recently had a patient of us who had been quite hesitant on vaccines, really asked me about what we meant by herd immunity, particularly given that we know with the Delta variant that even vaccinated individuals can acquire as well as transmit infection. And so for some of those who are on the fence, some of our messaging has caused a lot more confusion around vaccination. And our focus has also been on refuting misinformation. And we sometimes fail to address some of the sentiments that hesitant or anti-vaccination individuals may have, including some of our approaches around personal choice versus societal choice and trust of decision makers, including vaccine manufacturers. And over several vaccine campaigns, not just COVID, but vaccine campaigns and public health campaigns, it's evident that communication that fosters trust between scientific authorities and the population are likely to be more effective compared to our earlier approaches, for example, in HIV or smoking and cancer prevention that were very heavily fear-based. Approaches that really try and tag on positive emotional language can be highly effective. Approaches that understand the beliefs and values and take those into consideration, as well as some of the emotional connections that can be made, particularly with local trusted voices. So moving on to that, who are the trusted voices in vaccine delivery? And these can be politicians and public institutions, religious leaders, community influencers, healthcare workers, and all of the above, with the local context being very important in determining who are those trusted voices. I like this graphic because it reminds us that the trusted voices change with time. And in some places, politicians and institutions may not be the most trusted voices. So this is over the last 60 years. And the question is, how do you trust your head of government in this case to do the right thing some of the time, all of the time, etc. And less than 20%, and this hasn't really changed much with the new administration, trust the leadership to make those decisions. And certainly in the US, it's much less within Congress. So it's really important to understand who is delivering the message, and low trust institutions may not be very well positioned to convey an effective COVID vaccination strategy. And so looking at Africa, where who are and what are the trusted institutions? And this is an interesting study from the Brookings Institute. I would sort of take the data with a grain of salt, because it's very difficult in unfree societies to really get a true sense of trust, particularly of government institutions and the presidency. But what I think it mostly conveys is that there is different levels of trust across different countries, and likely within different countries, and whether it is trust of the presidency, the political structures, government structures, or trust in traditional and religious leaders. And it's important to understand the local context in terms of deciding which group of individuals become the most influential when trying to deliver public health messages. And this is a nice study done on a trustworthiness index across countries in Europe, North America, South America, and Africa. The only African country in this data set was in South Africa. And across the board, it was interesting to note the professions within the community that are among the most highly trusted, and scientists, doctors, and teachers came out on top. And many of these folks interact with various segments of society, and it's critical within the local context to understand who those trusted professionals, community leaders are, and equip them with the capabilities of delivering accurate public health messages. And in addition to the politicians and professional and community leaders, celebrity influencers have been used in public health campaigns over the several centuries. And here on the top left corner, I show Philip Lutayo, who some of you may know, but he was a Ugandan pop musician in the 80s, and one of the very first people who publicly came out as having HIV. And his public announcements were really important in trying to remove a bit of the stigma from HIV, put a face towards HIV, and really start the conversation going. And so these celebrity influencers can really have a huge impact within a society around getting conversations going, developing some understanding, empathy, and literacy around infectious diseases and public health messaging. Similarly, down below, Elvis Presley was used in the 60s as part of polio vaccination campaigns to try and encourage young people to be vaccinated. And more recently, Olivia Rodrigo at the White House, again, trying to get the message out to young individuals about the importance of being vaccinated. But it is also incredibly important that these trusted voices need to maintain that community trust. And once you lose it, the outcomes can be devastating. And this is a reminder of the governor of Texas, Rick Perry, who put out a mandate around HPV vaccination. It later turned out that Merck had made a relatively small contribution to his political campaign, but he had minimized that contribution. And what ended up happening was increasing a lot of mistrust around vaccines, particularly in a state that already had a lot of mistrust, and really led to that state falling significantly behind, and with subsequent healthcare consequences to the population. So having trusted voices is really important, but those voices really need to maintain the trust within the community. And those voices don't have to be celebrity voices. This is some really nice work done by Danuta Kaspriska and Dan Montano and Zachiri in the University of Zimbabwe, around voluntary male circumcision, medical male circumcision campaigns as a prevention tool for HIV. You could consider this as a surgical type of vaccine. And they did some very nice, diligent work, really trying to understand within the communities what kind of messaging would be most effective in driving uptake of vaccines. And in their work, at times, the celebrity leaders were not the most effective, but community trusted voices. And that could be the gogo, the ambuya, the grandmother in the community, really talking to issues around culture and you know, how to shift the conversation. So in this message, it's not about culture, it's about health. It could also be local elders, fathers and their sons showing that they've been vaccinated, they don't have any safety concerns, and there is a lot of data suggesting the influence of close people to you, your friends, your brothers, your uncles, in helping to drive that. So the trusted voices can be as simple as parents, mothers. You know, what will my mom think if I don't get vaccinated and I go to a party and put myself and maybe others at risk? The elders, and those can be traditional leaders such as chiefs, as well as religious leaders. And it's really important in doing this work to target the messaging to the right group. So I'll just end with a bit of an update and a provocative statement on this. But if you look at the data globally, and I downloaded this about a week ago, countries like the UAE are doing very well with vaccination of eligible populations with rates quite high. The United States is somewhere in the middle, and many African countries are lower down in the range of coverage. And the question is why? And so the WHO put out, I think also about a week ago, this tweet praising sort of 13 African countries that had reached at least 10% of the population being vaccinated. And if you look closely at this list, only 4 of them are above 20%. Most of them are below that threshold. And then if you look at the data more closely, most of the high-performing countries have administered less than 50% of the doses. And the tagline on this tweet is that crippling vaccine supply shortages have slowed down many countries in the region. And I wonder if this is correct. I think so much of the focus, and rightly so in the early stages, but should not be the sole focus, has been on manufacturing and supply. There are very real challenges around the distribution and the last mile distribution, but a really critical component is vaccine uptake, who actually shows up and who ends up being shot in arms. And I think that's what's driving some of the relatively low rates of doses administered versus doses received. And as part of the reason why it's really important to understand this and develop communication strategies that really can target this and use the trusted voices and develop social norms around vaccination. This was a nice study done in Bangladesh just before vaccines were available, really looking at the determinants of uptake to vaccines. And the factors that they found to be important, and I've highlighted the ones that are most significant, are perceived self-efficacy. So what is your ability to actually conduct the behavior that is being requested? Is it possible for you to actually get vaccinated, and what drives that self-efficacy? Perceived social norms were very important and significant. So what are the attitudes of others to behavior, as well as, more importantly, what do you actually do to take up that behavior? The perceived positive consequences, negative consequences of not getting vaccinated or having the disease, access, your risk perception of susceptibility and perception of severity. This has been one of the challenges with vaccinating young individuals who might have a perception that they're not at risk of severe disease and think about delaying or deferring vaccination. Perceived action efficacy is really important. So really understanding what the impact of the action has on efficacy. Divine will and religious beliefs are important, as well as the policy and local cultural framework. But the social norms is a really important driver of vaccine influence, and those can be injunctive norms. So what does the rest of the society expect you to do? And would you be judged negatively for not complying with those expectations? Versus the descriptive norm, which is really about what people actually do versus how they think they should behave. And I'll end with this interesting model that our colleagues from Zechire working at UZ on a male circumcision really used to try and drive the right messages and defining the right trusted voices. And I think it's a useful framework to think about these things, because not all of these factors apply to all individuals and will vary from society to society, and within a society, different groups. But there are environmental factors, whether social cultural factors, your capacity to actually perform the behavior, and some of the structural systems constraints, such as health delivery systems, access, availability. And then there are the individual factors. How do you feel about the behavior? What are the social norms? What are the beliefs and others' expectations of you in performing that behavior? And what are the barriers to that behavior and your beliefs of the efficacy? And it's interesting, particularly around different interventions, these factors will vary and weigh differently in different populations. And so it's really important to understand locally what those factors are and to tailor the messaging appropriately to help drive the health-seeking behavior that you're hoping for, and in this case, vaccination. So I will conclude by really just reminding you that vaccine hesitancy is as old as vaccines themselves. It's typically not easy to introduce a new health intervention, particularly vaccines. There is a continuum in hesitancy, and targeting communications to the right group is going to be very important for reaching high levels of vaccine coverage. Understanding the local context is very important in developing locally relevant messaging, and building an effective vaccination strategy with the right trusted voices to develop the social norms within a community will be critical in driving improved vaccine uptake. So thank you, and I will stop here for any questions or comments.
With many thanks, Tariro, for what is one of the most thoughtful and thorough presentations I have heard on the subject. And you were meticulous in terms of dealing with all of the issues. I mean, I have lots of questions. I'm trained as a sociologist, and when I listened to you, what I heard was the new curriculum for the sociology of health in the light of the COVID-19 experience. And I think the social sciences have been a bit late to the party in some ways, but it's also true that very little investment, certainly compared to investment in vaccines, has been put into elaborating the social science, which is really needs to be corrected, actually. So thank you very much for that. I will not pose my questions. I'm going to turn immediately to Janan Dietrich, who started at the Perinatal HIV Research Unit in 2007 as a social scientist, and progressed to become the Director of Behavioral Research at the PHRU. Additionally, she's an associate researcher at the University of Witwatersrand and a consulting social science expert for the HIV Trials Network and an investigator of the Canada-Africa Prevention Trials Network. So as you can hear, she has a great deal of experience and expertise. Just to mention that in 2013, Janan received prestigious awards from the University of the Witwatersrand, the Harvard Center for Age Research, and the National Research Foundation of South Africa. So over to you. We'll pick up on questions to Tariro, to Makadzange later in our conversation.
Thanks, Wilmot, for that kind introduction. Yeah, thank you, Dr. Makadzange, for your very comprehensive presentation. I must say, as a social scientist, I really applaud you for all of the aspects that you were able to raise, and I really like that. You know, what I picked up in the end is that there's a multidisciplinary approach that's needed to health. And really, particularly as we are dealing with COVID-19 vaccine hesitancy, it's really going beyond the biomedical model and working so closely with communities. And as you were saying throughout your presentation, those trusted leaders that people reach out to, because they're not making decisions about taking a COVID vaccine in isolation. You know, they're not sitting in their room and deciding on their own. Often in the setting that I'm based, which is Africa, and particularly South Africa, people make decisions, like you were saying, they consult their gogos, they consult the grandmothers, they consult the elders, their local leaders, and it's a combined decision making. But so often the Western strategy is that decision making is made on, you know, a person makes the decision on their own. I also want to say that I like that you drew so many parallels between HIV and COVID-19, because there are so many lessons which we can learn and apply from HIV. For instance, once again, I want to reiterate, with HIV, there's a huge focus on addressing stigma and working with communities, addressing local stigma, addressing really understanding the local context. So for me, that was quite important, because most of my expertise is in with HIV, and particularly within the HIV Vaccine Trials Network, where there's quite a huge focus on community engagement. And I want to agree with what Wilmot was saying. From my perspective, in addressing COVID-19, there was huge development with vaccines, but the community engagement lagged behind. And so eventually, when there was a vaccine and we now had to take it to communities, there was high hesitancy. And there were lots of misconceptions, misunderstandings that simply wasn't taken into account. And so I think if we early on had learned from the HIV field, if we, as we were developing the vaccines, you know, also work together with communities, maybe things would have been different in terms of the vaccine hesitancy. So I also want to touch on the model that you presented on the confidence, complacency, and convenience, and especially around the confidence, where you spoke about the science and the communication. It's very important about, you know, who talks and how we say something. And often within science, you know, we think that the scientists are the ones to be conveying the messaging and the communication, and no, often that's not the case. In fact, in most cases, that's not the case. People want to hear from their local leaders, and they have local nuances which are not addressed through generic messages. And often a lot of the vaccine hesitancy is rooted in fear. You know, it's, yes, there are side effects, but how does the side effects relate to me who might have diabetes? You know, is it going to affect, am I going to have more side effects if I take the COVID-19 vaccine? So it's really getting to the nuance of people's fears and understanding what they are, to get them to the point where they are making that behavioral change to go for their COVID vaccine. And then also in terms of the complacency, I really like, within my own work, it's so important to go beyond the biomedical model and traditional models of health. And so in South Africa, I was, you know, just anecdotally, I am doing quite a bit of qualitative work in understanding people's concerns about COVID-19. And one of the people that we interviewed said that when you end up going to a medical doctor, you can be assured that someone has already gone to a traditional healer first. But the medical doctor assumes they're the first person that they're interacting with. But of course, your patient is not going to say to you, I went to the traditional healer first. And it really spoke to me about how important the local traditions are in addressing vaccine hesitancy, and really understanding people's context in how they interact with the health system. Yes, so those were my thoughts about your presentation. And I also wanted to speak briefly, if there's time, about a project that we are conducting in South Africa and Zimbabwe, which is called the Vaccine Information Network Pilot Study, which is really a rapid assessment of trying to understand the local norms in addressing COVID-19 vaccine hesitancy. And the mission, or the main aim of our project, is to try and understand, to really address a critical and unmet need by providing the local governments and key stakeholders with critical information to deliver effective campaigns to promote COVID-19 vaccines. And the pilot intervention is really a first of its kind in Africa, so South Africa and Zimbabwe, to improve vaccine uptake among those who are taking a wait and see approach. They stuck on the fence, and we can change their minds. We can assist them to get to the point where they do actually go for vaccination. And it's quite local in its approach, in that we're going to work with local leaders and influencers, and really taking a local context approach to address local instances of vaccine hesitancy. The study is going to be conducted in 4 phases. So phase 1 is to conduct a survey and addressing many topics of vaccine hesitancy. Phase 2 is going to be qualitative, which gives us the opportunity to really understand the nuance in these local context. And then phase 3 is really, I think, the most exciting part, because we will be able to work with our medical doctors, social scientists, brand strategists, and also communication experts, and then work with the local influencers and local leaders and develop a messaging framework to address vaccine hesitancy in these local contexts. And then so in the end, we'll have a broad communications framework which we can share with local governments, and hopefully through this pilot, we'll be able to show that we can scale up this approach to many sites across Africa. So I will end by saying, because I'm sure my time's almost up, that in addressing health, it's important to take from at least from my perspective as a research psychologist, it's important to take a community engaged approach or a user designed approach where we work with people, we understand their needs, we understand what it is that's important to them, and merge that with the public health and needs. And I think through doing that, and I know this through my work with HIV, when we do take this approach, we have better outcomes because we are working with people and they can see that we are also interested in them. You know, we're not just interested in taking a vaccine or a product, but we're also ensuring that we're taking their needs into account. So I'm going to end there. Thank you.
No, thank you very much, Janan. That was really excellent. Before I turn to Hassan Mohamed, I just wanted to pick up on one point. The first is the question raised about trust in local leaders or regional leaders, and the point that Tariro made about context understanding, in which is important for understanding how much trust you often need to build or rebuild depending on that local environment's history. So, for example, in the case of South African HIV, a long period of HIV denial, and what a heavy lift it is then to rebuild trust. There are certain pockets in Africa, large, where there's major mistrust of what the big pharma companies are doing globally. I mean, whether it's true or not, but there's a history there as well, and they need to contend with. So, just your comments on, from your experience, what a particularly heavy lift it is to build trust in an environment where the medical interventions that were proposed, in fact, had consequences that were not very good, or there's a history of denialism. I wanted to ask Tariro that question.
Yeah, thanks, Wilmot, and I think it'll be interesting to hear Janan's perspective as well. It is very, very challenging, particularly where you have had political leadership that, in the US, they talk about the president having a bully pulpit, but it's a very vocal pulpit. So I imagine in South Africa, and I'm a little less familiar about that, the impact of some of the denialism and questioning was very, very broad, and really is amplified by the speakers, the voices that convey those messages. Regaining that trust can be very challenging and really needs to be done intentionally. So whether it is thinking about how do you shape messages that get to the questions that people have and are conveyed in a way that is emotionally connected. So with HIV, I think one of the big factors is that, politicians, et cetera, can say one thing, but because HIV really touched all of our lives, I don't think there's any, especially in Southern Africa, I don't think there's anybody who was not touched by HIV in one way or another, either directly, personally, or through their family and family networks. I think that had a huge impact in bringing the message home that this was a real disease and helping some of the important health messages really get to the front, whether it was about antiretroviral therapy or about prevention strategies, et cetera, because there was that strong personal emotive connection that helped to make the messages much clearer and to improve some of the health-seeking behavior. And then obviously sort of seeing what the antivirals, for example, did for people with HIV became really important in driving the right kinds of behaviors. But certainly, building trust, whether it's with governments or the pharmaceutical industry, really takes time. And some of it is historic in nature, some of it is perceived, some of it is real. But you have to meet people where they are, try and understand what's driving those concerns and tackle them head on. But I think for HIV, certainly the personal experiences and really touching on that became very important in shaping the narratives and the communication strategy and subsequent approaches.
Thank you. Janan?
Yeah, I want to agree that building trust takes time. It doesn't happen overnight, but also it's ongoing. It's not once off. You can't go to a community this month and then you disappear. That's not trust building. It's continuous. You have to constantly engage with key people, key leaders, and like Tariro was saying even in her presentation, that these leaders might change. So you have to know what's happening in your communities. You have to have your finger on the pulse all the time, because things change so rapidly. And if we link that to COVID-19, there are so many changes taking place all the time. And I don't think we've been fast enough, not we, but just generally, I don't think government has always responded fast enough. If I think about when the pandemic started, there was almost like a relaxed approach taken. COVID is like the flu, don't worry too much about it. And then 2 months later, governments went into lockdown. Then it was a fear-based approach. So then we moved from this relax to fear, but we didn't tell people why. And so even till this day, as I drive to work, people are still calling in and wanting to know from journalists. They're saying, last year you were saying we shouldn't trust government. Now you're saying we should, but you're not telling us why. And so there's still this gap that has to be addressed. And that's why it's so important to be working with these trusted voices, to be working with these local leaders in these trust building. And we have to do it continuously.
Yeah, so thank you very much for that. So there's one survey done by the Africa Center for Disease Control together with Resolve to Save Lives, called PERC, that looked at the top reasons why people trusted certain kinds of institutions and leaders. And it's very interesting that in the case of 5 countries we looked at, Ethiopia, Kenya, Tunisia, Nigeria, and South Africa, that it's only in the case of Ethiopia that the media even featured as a source of information. In no other country did it. It's not the most trusted in many parts of the world and Africa. And in the case of Tunisia, the most trusted institution was the military. So those are all the contextual things. In Congo, in the DRC, the most trusted institution is the Catholic Church, and so on. So this issue about trust, who has it, who possesses it, how they acquire those qualities or how they diminish those qualities is an interesting ongoing thing. And you're quite right. We are going to have to battle this pandemic for the next 3 years, not just for the next year. And at every turn, there is a flow of information that's required, that's science-based, that has to be continuously communicated in an honest way and consistent way to the public. Otherwise, you create confusion. So thank you for those initial responses. I'd like to turn to Hassan Mohamed, and it's a really fabulous that we're turning to him because he's involved very directly with a government, this case, the government of the Western Cape, its health department. And just to say that Hassan is currently a public health medicine specialist in the Department of Health in the Western Cape, as I've pointed out. And he's also in the Department of Global Health at Stellenbosch University as a faculty association. What he does for the Western Cape is provide technical support for planning, monitoring, evaluation, health systems reform, health information systems development, and outbreak response. So he's played a key role in coordinating the province's response to COVID-19, including the vaccine rollout. So very pleased to have you, Hassan. Over to you.
Thanks very much, Wilmot, and thanks very much to my colleagues, the two previous speakers who really gave excellent presentations. I'm going to share a presentation also just to provide some local context. And Wilmot, if you can just confirm when it's in screen mode.
Yes, it is. I can see it, and all of us can see it clearly. Thank you.
Okay, great. So I'm going to go through these fairly quickly. So just giving some context, in a population of 58 million, that's South Africa. Those are the numbers of cases and deaths that we've had. We have 9 provinces in South Africa, of whom the Western Cape is one, and that really just gives a very, a rapid overview of the number of cases, hospitalizations, and deaths that we've had so far reported. In terms of vaccinations, nationally we've given 17 million doses, of which 2.85 million is in the Western Cape. In terms of coverage at the moment, the Western Cape is slightly ahead of the other provinces, percentage of the adult population who've received a single dose. One of the big challenges though, and that 40% belies a big issue, and that is the difference between the affluent and the poor. And what this graph shows is that the insured have a much higher rate of vaccination or uptake of vaccination compared to the uninsured. The insured make up 25% of the population. In terms of a national survey that was done, what are the reasons that people were worried, or reasons for vaccine hesitancy? You can see that side effects or lack of belief in effectiveness, and of course a proportion who are against vaccination are the main reasons for vaccine hesitancy as reported by this particular national survey. Well, who do people believe and who do people want to hear from? So interestingly, health practitioners, medical practitioners came up in a Western Cape survey that was done as the most popular group by far. The second most popular was nobody, people trusting nobody, which is also, I think, an interesting statistic. We've discussed a lot about trust, and this is really confirmed by the study done by a colleague who's actually in attendance here, Janan. And I'm going to show a couple of slides where she's done work in mainly poor communities, showing that there's a clear relationship between trust and lack of willingness to take a vaccine. So again, from her work at the local level, people do want to hear from scientists, teachers. So this is very much Tariro in line with the data that you showed, youth leaders, influencers, doctors and nurses, pastors and imams, and so on. So these are the kind of people that people do want to hear from with respect to vaccination and COVID vaccine. And I think just the last couple of slides is really, well, what have we done? We have a program called Boots on the Ground, of which a part is to do with communication, a part to do with mentoring and informing people about vaccination, and of course, importantly, engaging with important stakeholders. So again, you probably won't understand most of the abbreviations here, but the headings are important: government departments, we've engaged with a whole range of them. And then, of course, community-based organizations of one kind or another, trade unions, private companies, etc. So I'm going to stop sharing, but just make a few additional comments, based on what Tariro and Janan have said, and that is really just to affirm many of the comments that they've made. I think, trust does take time to develop. We do need to engage and speak to people. And I think the way we phrase the work that we need to do is, this is not a sprint, it's a marathon. So it's something that's going to take time. Yes, the community leaders are important at the local level, but we need to ensure that the community leaders are informed. So we have a program where we engage with community leaders of various kinds, run information sessions, talk to them, engage with them, develop partnerships with them. I mean, the question of trust is one where we were shown to be lacking, if you like. When we realized that we had to run this massive vaccination program, something completely new, we found that our relationships with community organizations, with other sectors in society was weak. It's something that needed to be worked on, needed to be developed. So certainly, it's valid that we need to raise concerns with respect to that. In terms of traditional healers, we have also been engaging with local traditional healers. We've arranged vaccinations for community-based traditional healers. A small percentage of them have attended, have come forward for vaccination. But again, it speaks to relationships. It all comes back to that. Have we developed adequate relationships with many of these key stakeholders? How do they trust what we say? Certainly, trust in government is low. So it's very important that we engage with the multiplicity of leaders that are out there and get their support to take this vaccination program forward. I think in terms of vaccine, I think just in terms of anti-vaccine sentiment, I think the last comment I want to make is really just that we need to be very careful about having a polarized debate about vaccine hesitancy and making sure that we distinguish anti-vax sentiment, which is more almost like an ideological opposition to vaccination, with someone who's not sure, someone who's uncertain. And we need to move away from polarizing the debate by using language that blames, that isolates, that belittles people because they choose not to be vaccinated at a particular point in time. Yesterday, we heard at one of the vaccine sessions where quite a small proportion of people are against vaccination, but there's a group referred to as apathetic. I was a bit concerned about that particular term, and I would rather phrase it in a different way and say that vaccines are not necessarily the priority for a lot of people. We know that in poor communities that vaccine uptake is low, but apathy is not quite the right word. It's more to say that people in poor communities have many pressing, real basic needs in terms of priorities. And vaccination is not on the top of that list of priorities. So it's using strategies of going to people, engaging with people, of course, using trusted voices, using local influences as part of that strategy. But I think it's also an important aspect is giving people, enabling access. And Tariro, I think that came through in your presentation as well, is that, one needs to look at the full picture and look at what are all the contributing elements to what we are referring to as vaccine hesitancy, and how do we address all of these, in a holistic way. And I'll stop there. Thanks so much.
Thank you very much, Hassan, for that walkthrough of what you're encountering from a public health, public sector point of view in terms of running a program to maximize vaccine uptake and what the obstacles are and what the barriers are and so on. So, and one of the things that clearly that you're completely familiar with is how important it is to understand the local barriers that people face. And those local barriers can be, you know, I have to take off from work. So the real opportunity costs, the real costs that people have to for travel, the opportunity costs in terms of time lost, and a range of other things. And that is mixed up with a whole range of other questions as to do with vaccine hesitancy and so on. So, and from a public policy point of view, where you then intervene obviously matters in order to, so I'd like to hear more about where you're struggling and where you're not struggling, because that's not always predictable, and so on with it. But let's turn to Jonathan, and then we can pursue the questions that we may have as panelists, and also I need to present you with some questions from the audience as well. So to introduce Jonathan Strysko, and I hope I'm pronouncing your last name right.
You are, thanks.
Okay.
Yeah.
Yes. Who is with CHOP, the Children's Hospital of Philadelphia, and is also part of the Botswana-University of Pennsylvania partnership, the BUP. To say that Jonathan has been in Gaborone, Botswana for the last 2.5 years. So he's there. He's a David N. Pincus Global Health Fellow. He completed his pediatric and chief residency at the Maino Mides Infants and Children's Hospital of Brooklyn. I'm sure I pronounced that incorrectly. And spent 2 years at the Center for Disease Control as an epidemic intelligence service officer at the National Center for Enteric and Zoonotic Infectious Diseases. So he serves on the National Pediatric Task Force while continuing clinical service at Princess Marina Hospital, and teaches also at the University of Botswana's Faculty of Medicine. Thank you very much for joining us, Jonathan. Over to you.
Thanks, Dr. James. Good afternoon, everyone, or good morning, whichever applies to you. It's really an honor to take part in this conversation. I really appreciate being included. Dr. Makadzange, Dr. Dietrich, and Dr. Mohamed, you've really provided such rich information and analyses already, so probably most of what I'll be talking about will be variations on themes you've already introduced. But as Dr. Makadzange said, context really matters when tackling vaccine hesitancy issues. So I'll quickly turn the lens on the context in which I work here in Botswana, and sometimes the very specific ways that hesitancy arises, and also about where I think could be important opportunities to build community trust. So Botswana is a landlocked nation with a population of about 2.4 million. 70% of those reside in urban or peri-urban areas. Botswana really prides itself in being an exception in the region. It's famous for its history of nonviolence and peaceful transfers of power. And unlike all of its neighbors, it was never really colonized per se. It was instead designated as a British protectorate. And much of the last century was about the lengths which were taken to avoid foreign encroachment by racist states, including apartheid South Africa. Diamonds were discovered shortly after independence, which occurred actually coincidentally 55 years ago today. So happy independence to any Botswana listening in today. So now mineral wealth has made it an upper middle income country with one of the highest GDPs per capita in Africa. But I hasten to add that this designation largely obscures the fact that Botswana has the third largest income inequality in the world, outdone only by South Africa and Seychelles. But in general, this exceptionalism pervades operations in Botswana. There's a hesitancy to rush into new things, and because just because everyone else is doing them, we don't have to do that. And history has proven that there's a kind of wisdom in this, and in waiting things out and weighing things thoughtfully. Unfortunately, though, it doesn't jive well with a rapidly advancing pandemic and the thought of a hastily developed vaccine that potentially cut corners, although we know it was red tape and not corners which were cut, has been the basis for some hesitancy here. Botswana has a long-standing history of commitment to equitable healthcare delivery. Over 85% of Botswana's population lives within 5 kilometers of a healthcare facility. It has the 4th highest HIV prevalence in the world, but one of the most successful PMTCT programs, and ARVs are freely accessible. Under 5 mortality has made some real advancements in the past few decades, partly due to some game-changing vaccines, including the pneumococcal Hib and rotavirus vaccine introduced in 2012. So traditionally, vaccines, especially childhood vaccines, are very well regarded in Botswana. There's very much a normalcy surrounding this and an expectation and responsibility attached to it. For example, in February of this year, Botswana conducted a pretty massive measles vaccination campaign, and teams were mobilized and people dutifully lined up for hours in the middle of a pandemic, including my own 4-year-old, to get their measles jab. So traditionally, vaccine hesitancy has been all but non-existent, only seen in a subset of religious minorities. But we're all very aware that the rate at which social norms and public opinion evolve seems to be much faster in the age of social media, and certainly the pandemic has shook things up in every way. So a little bit about what COVID has looked like here. Botswana was one of the last countries in the world to record a COVID-19 case. So again, we don't like doing what everybody else is doing. And we didn't document community transmission until August of last year. Botswana's early pandemic mitigation measures will likely be remembered for being quite strict. For example, following the first recorded cases, we went into a 48-day lockdown. You could not leave your house unless you had a permit. This was enforced by roadblocks manned by military police. Universal mask mandate has been in place for the past 18 months, with hefty fines of up to 5,000 pula or $500 have been issued for failure to comply. There have been alcohol bans and curfews, the whole 9 yards. And initially, these measures were quite successful. When you compare the epi curves between South Africa and Botswana, you can see that in the winter of 2020, Botswana, through that aggressive centralized campaign, probably evaded the first wave experienced in neighboring South Africa. But unfortunately, the winter of 2021 was a completely different story as we collided with the Delta wave. And for most of July and August, ICU beds were at full capacity. There were oxygen shortages. Transmission was happening in our wards. And during the Delta wave alone, in our just one neonatal unit, we had 5 babies born to mothers who died of COVID. So I think this, I would say that this collective trauma, more than anything or that anyone has said or done, has galvanized public opinion around the need for a COVID vaccine. People who had a kind of apathy about the vaccine before the Delta wave, or lower priority, as Dr. Mohamed would call them, they fairly quickly changed their tune, and virtually everyone is trying now to get away to get their vaccine. But the story, of course, now isn't so much about hesitancy, but instead about access. So everyone thought that Botswana, being a small country with a fairly well-oiled system of rapid vaccination campaigns and a self-financing participant in COVAX, would be a great place to go big and reach herd immunity and get the economy back up and running. But like so many countries in the global south, we saw vaccine shipments trickling in like crumbs falling from the table of wealthy countries. And 6 months after our first vaccine shipments arrived, we've only vaccinated 13% of the country, and our population is only 2.4 million. So to me, supply chain is far and away the most important issue at hand. But still, I think we need to, we'd be naive to think that we'll be able to coast on social norms, which have remained so stable in Botswana for generations. And as Dr. Makadzange mentioned, vaccine hesitancy never really leaves. It's always sort of dormant, ready to rear its head based on cultural and political dynamics. And I think one thing that we need to pay attention to is that here in Botswana, vaccines have been available for healthcare workers for about the past 4 months, albeit with many stops and starts due to stockouts, but still only 60% of healthcare workers are currently vaccinated. And as we saw in the presentation earlier, healthcare workers are one of the most consistent groups cited across a diverse range of populations, which are trusted sources of information. And yet we can see signs of a kind of crack in the foundation with this very sobering 60% of healthcare vaccination rate. And we see this playing out all over the world. Healthcare workers are not a monolith. They come with their own filter of political and cultural identities and ideas. And it's a reminder that medical education is highly variable, and the way that modern medicine is going to, globally is that healthcare is becoming very siloed, very specialized. Public health and clinical medicine are often quite far apart from each other. So it probably shouldn't come as a surprise that, a dialysis nurse, a neonatologist, an orthopedist, they might all come to different conclusions when looking at the same available data on the pandemic and vaccines. And not only are healthcare workers highly diverse in their educational backgrounds, but the ways in which continuing education occurs across specialties is highly variable. And in some places, continuing education is really not embraced in the way that it needs to be to keep up with a highly evolving world and a highly dynamic landscape of healthcare. So I'll just end with a little anecdote. A few months back, we got our first meager shipments of Sinovac and AstraZeneca, and one of my good friends who was a nurse in our pediatric surgical ward was pulled from the ward to be part of the immunization team. And given the speed with which they needed to get shots in arms, there wasn't a lot of opportunity for this team of nurses to ask questions about the vaccine, to figure out how to message adverse events. Dr. Dietrich said it earlier, people want to know about individual risk factors. What if I have a family history of bleeding disorders or coagulopathy, to understand what those adverse events could be. It was just, we're in a race against time, the benefits outweigh the risks, the statistics are in your favor, just get shots in arms. And in the case of this nurse, she expressed some hesitancy. In our setting, anecdotes are oftentimes much more powerful than the statistics. And we have a now famous case of a Ministry of Health employee who was one of the first people getting the AstraZeneca, who experienced some sort of life-threatening event around the time of the vaccine, and actually an independent review committee deemed it likely to be associated with the vaccine. But for this nurse, despite the powerful anecdotes that were causing some people to be hesitant, she had gotten COVID herself, and this one anecdote was now being counteracted by the now many, many more anecdotes of COVID-19 claiming the lives of friends and loved ones. So in summary, I'd say that communities need to look at the dynamics very specific to their local context. I haven't really dove into rural areas in Botswana, which are very much influenced by chiefs and tribal leadership. But if I were to make the case for one group, it would be healthcare workers. They are trusted voices in the community, but we can't take them for granted. And we need continued engagement to keep up with the pace of science and in these very dynamic times. So with that, I'll hand it back to Dr. James and the rest of the panel.
Thank you very much, Jonathan. So, the broader picture, colleagues and friends, is that we're going to battle in the developing world for sure with COVID-19 as an increasingly endemic situation when it comes to COVID-19. And one of the first constraints that we face right now is vaccine supply and acquisition. But it's also clear, given the projections, that by the middle of next year, there'll be 3 times as many vaccines that's required to actually inoculate the population. And so we're going to be in a situation in the future where countries will have, there'll be multiple choices, different vaccines. There's a question of boosters. In what sequence do you take them? Can you take one vaccine as a booster or not? And so the science landscape is going to shift very, very quickly. And we have to rapidly adjust to that in terms of communicating what the effects are, the safety levels are, for example, when it comes to vaccines to the population in order to drive vaccine uptake. It's also true that the fact that supply issue in Africa in particular has been so terrible does have negative consequences of vaccine take-up itself. So there's an issue to constantly adjust strategy and tactics over the next 3 years. So we have to be fleet-footed, we have to be quick, we have to adjust very fast. This is not a once-off affair. There were 2 waves during the so-called Spanish flu. We're dealing with heading into 4th waves. So thank you very much for that walkthrough of issues. I wanted to give the panelists a chance to exchange views if they'd like. Otherwise, I'm going to turn to some of the questions in the chat so we can respond to those. So I've got Hassan, go ahead.
Thanks, Wilmot, and thanks, Jonathan, for your input as well. I mean, I found it interesting. I mean, I'm relating your input to one of the comments in the chat, or possibly it's one of the questions, which is about, you know, there's this, I suppose, desire to hear from experts, from doctors, about the vaccine, that they are one possible group of trusted voices. But, you know, amongst them exists vaccine hesitancy and anti-vax. So there's the potential for it being a double-edged sword. And I think one of our, and I mean, I'll just share an interesting story there, where in the health department, we've vaccinated now just over 70% of our health workers. So 30% not vaccinated yet. But after the initial wave, it was about 64%, and it's taken us about 3 to 4 months to add another 7% to that group. But we've disaggregated that, and I mean, amongst doctors, it's highest. Just over 80% of doctors are vaccinated. Amongst nurses, it's 70%, but amongst clerical staff, it's about 50%. So there is this interesting diversity. And it comes back to the discussion we're having today, is who are the trusted voices? Are health workers those trusted voices? I mean, I think one needs to perhaps qualify that and say, you know, that, you know, not all health workers, because we do have health workers promoting anti-vax messages. So we need to think about how we communicate that. And Tariro takes us back to your point about communication. How do we communicate? What's acceptable communication? What's reliable, credible information? And again, it goes back to a more fundamental point in our society, which is, you know, the ability to think critically and to evaluate evidence. Can't start now building a culture of critical thinking and getting people to understand that not all information is equal, and that some information is based in solid science and others are not. And I mean, I think it's really just one of those, I think, difficult challenges that possibly impacts on health workers playing the role, or in fact any group playing the role of being a trusted voice. You know, we say community leaders, but there are, of course, community leaders who do not support vaccination. So it's an area I think we perhaps just need to apply a bit more thought. Thanks.
Yes, indeed. And in fact, in certain quarters, it's also organized and organized around health workers. So you actually have a campaign at the center of which you have health workers as well. So, I mean, it's not often you see that, but it does exist, as you all know. So, Janan, you wanted to comment?
So this is actually for Hassan. Hassan, in your presentation, on one of your slides, you stated the amount of excess deaths. So, there's deaths that you can easily, I'm sure, track because of COVID. And then there are excess deaths. So more people have died, but I'm sure perhaps many of them didn't go to a health facility. The reason I thought this is so interesting is because there's so much stigma around having COVID, and also that COVID doesn't exist still. And I'm wondering if in your data, there's a way to see if there's a link between stigma around COVID and then to be able to link that with vaccine hesitancy. I don't know if you're able to do this, but I was just thinking it would be so interesting to be able to look at the data in that way.
Yeah, sure. That's a fascinating question, Janan, and I don't have an answer. Of course, both cases and deaths are underreported. We know that. And, why we can argue that excess deaths, because again, this is what COVID denialists argue, is that, well, how do you know that these excess deaths are COVID related? And we can argue that because they follow exactly the COVID waves from the reported cases. So, the evidence is fairly clear. Of course, not 100% of them are COVID related, but they follow the waves. So, that's good evidence. But is the fact that people are dying related to the fact that they are denialists, or that they're not, or maybe that's a strong word to use. Maybe there's just a lack of knowledge or lack of willingness to acknowledge that they may have COVID, and is there some relationship with vaccination? All I can say is that all of us receive, and I mean in government we receive loads of messages from individuals who are anti-vax, and there is a link in their messaging. They would start off denying the existence of COVID as a disease, pointing to the lack of evidence for the tests and so on, but then go on to arguing that therefore vaccination is not necessary. So in their messaging, they make the link, but whether, in the general community, there is this link, is something perhaps that needs to be investigated further. Thanks.
Thanks, Tariro.
Thank you. I just wanted to add to the really important issues that Hassan brought out, and that's the plateau effect. So, you get to 50-60% coverage, then adding each incremental percentage for uptake becomes harder and harder. And this is a phenomenon we're seeing in many places. Your early adopters come in quickly and take up the slots as they happen, and then you have to work harder to really get those rates high enough. And I think it's really important in that to think about that hesitancy continuum, because many of the early adopters are those that agree to all, have limited reservation, and the folks that we really need to get to are the wait and see group, the group that is more amenable, and sometimes it's over time, sometimes it's through highly effective communication. So thank you for really highlighting that, because I think for public health practitioners, that's the challenge now. The early adopters have come in early, stood in the lines, gotten a vaccination, and it's now how do you get to the rest of them. The second thing that I wanted to make a comment on was the vaccine hesitancy among healthcare workers. And that's really important because healthcare workers are an incredibly diverse group. And it's not only with COVID that we see this, we've seen this with other vaccines as well. And it's really important in sort of thinking about, the leaders who will be delivering messages. Who are they? What are their own sort of concerns and issues around vaccination? Are they the most effective in communicating a public health message around vaccines, and how do you effectively address their concerns? And those are true whether in Africa or the West. We do see high levels of hesitancy in our healthcare workers as well. It's interesting that for some vaccines, like the influenza vaccine, the way that health systems have managed to get some of the healthcare vaccination rates high is through mandatory vaccination. Because for a lot of the people in between, this is not talking about the minority that are on the extreme, refuse all vaccines. Sometimes that sort of carrot versus stick approach really does help you accelerate acceptance rates to higher levels. So at times you might need a combination of approaches to really get to the uptake and coverage levels that you need.
So thank you very much for those comments, Tariro. I wanted to, are there any other responses from the panelists? I wanted to turn to some of the questions in the chat. Okay, if not, if you can see in the chat, there's a wonderful conversation and sharing of information going on, principally in response to Joanne Carrigal, who started the chain by saying that her team developed and rolled out an extensive vaccine ambassador training program in the Western Cape province. And they trained thousands of community leaders in the vaccine and gave them tools to share in their own communities. They use the trainer approach to do this. And what's important clearly about that is that if you want to work with influencers and leaders, what is the message that they have to convey? And so message clarity is important, and therefore there's need for ongoing training. The importance about community workers and community leaders is that they're embedded in those communities, and therefore they have a trusting relationship with it. So it's important I just wanted to draw your attention to that series of comments and sharing of information by Joanne, and thank her for that. And also the responses. There is one question to do with adverse effects. If I can just get to the question. So there's a question where somebody asks how adverse effects are being communicated. And that raises the issue of understanding the difference between side effects and adverse effects, and how one tracks adverse effects and does something about that, and how one tracks side effects and why that matters. So I wanted to turn to Tariro first to ask her just to start that conversation in response to the question.
So thank you, Wilmot. I think it is important to recognize that all medical interventions have a risk profile and a safety profile, and vaccines in general are extremely well tolerated. And for the vast majority of individuals, they will either have no side effects or relatively minor side effects that are often transient and resolve fairly rapidly. So whether it might be, a sore arm for 24, 48 hours, fevers that self-resolve or can be appropriately medicated. But for the vast majority of individuals, reactions are pretty minimal and self-managed. And this is true for many vaccines and has been thankfully true for the COVID vaccines. that have now been dosed in millions and millions of people. So we have pretty good safety data emerging first from the clinical trials and now from real world data. It is important to realize that in a tiny minority of individuals, there may be more adverse side effects. And those are important to be aware of and for health authorities to track. So whether you've heard of some of the blood clot issues or myocarditis issues, etc., those are really important for physicians, for patients, for health authorities to be aware of, but to recognize as well in communicating to the public that these are relatively rare events. And some of them are of significant consequence. Some of them can be managed and resolved. Some will resolve on their own. So it's important in communicating that to help the general public understand that these are relatively low risk events. They're not zero probability events, but relatively low risk events. And that we have good pharmacovigilance systems in place to help sort of detect those events and where possible assist with managing those events. I think the last thing I would say is that I think some of the adverse events have become a rallying point around sort of not vaccinating or driving vaccine hesitancy. And it's really important in communicating this to folks to really point out that, we, for the vast majority of individuals, vaccines are very safe. And one might say vaccines may be the greatest invention in human history. We used to die of diphtheria, of tetanus, of smallpox, etc. And vaccines have really revolutionized human existence. Our life expectancies have changed dramatically because of vaccines. So for the most part, they have been an incredible contribution to human life and human history. But as with all interventions, there's relatively low risk, and some of these are in the 1 per 100,000, 1 per million range in terms of risk profile. So relatively low risk events that are important to be aware of. And as I really hope, as we understand science a bit more, we may actually become better at predicting how these very rare events happen. But for now, these are relatively rare events and don't negate the overall safety and human benefit aspect of vaccines.
Thank you very much for that. So, Hassan, could you also respond to this one question from Nicola Shongwe, who asks, in this pandemic, we have had an unprecedented number of self-proclaimed experts, people making home videos and broadcasting their messages through social media. Is this to be encouraged in addressing vaccine hesitancy, or is this a double-edged sword? If you could respond to that in addition to what you were going to say.
Yes, thanks. So let me start off with the whole issue of adverse events, and just build on what Tariro has mentioned. She's already given an excellent response. I think in a more practical sense, what we do is when we communicate about vaccines, we include the information about side effects. What can you experience? I think it's about taking charge of the narrative rather than leaving it out. Talk about the mild side effects, talk about the moderate and more severe side effects. And, so in presentations that I do, and I've done many to various groups, talk about the risk of clots and how rare it is, of other side effects that may occur with various vaccines. But make it clearer. I mean, I think be in charge, be informed, and be trusted. I think that's part of it. If you give people full information, it improves your trust level, even if there is some anxiety that's caused by the fact that there may be, some side effects associated with it. Secondly, there is the whole issue of reporting, and there is, I think, to answer that question as well, there are, reporting systems. We've got what's called AEFI, Adverse Event Following Immunization, and they've made it easier now so that a member of the public can use their phone to submit a adverse event report, for clinicians to report it. The systems have been made easier, and we encourage reporting. And that's important also to give confidence to the public that we are taking note, we are recording it. The one challenge, though, is giving feedback, and one can, of course, only give that in aggregated form. The challenge that we have is that, for confidentiality reasons, we can't really talk in detail unless we have permission, of course, about individual cases. And this is where, people opposed to vaccination don't apply any of those ethical rules. They talk about X who died at that hospital and after vaccination, or this person had a vaccination and 2 days later they died, and whatever. And it becomes more challenging for us to respond in individual cases because we are bound by rules. But nevertheless, the National Department of Health has put in place a system of feeding back to the public on investigations on adverse events, which is positive. And in our province, just last week, we had a national expert, Dr. Helen Rees, actually joining our media conference that we do on a weekly basis, and just talking in more detail about adverse events. So it's really engaging with the public and keeping them informed of developments. With respect to scientists and, this whole issue of experts, again, it speaks to the point that I made earlier on, which is one needs to be careful and be qualified about how one promotes the idea of people must listen to experts. One needs to include in that conversation the discussion around reliable information sources. And that's the way that I would promote it, is where do you get information on vaccines? You can get it from government, you can get it from the World Health Organization, and I promote the CDC as a source of information as well from the US, because there's useful, easily accessible, readable information from that source. But it's getting people to learn also about which information sources are reliable, rather than just simply say, listen to the experts. One needs to go a little bit beyond that. And I think in general, we need to develop a consciousness of critical thinking about how do people evaluate information, discouraging people from listening to WhatsApp messages from self-proclaimed experts. But, I suppose learning, as we've done over the last few months, what is a reliable source of information, from who? What makes it a person a reliable source of information? We need to engage in that, in those kinds of discussions with people, in parallel with encouraging, experts, legitimate experts, to talk about their field. Is, I think, thinking about it more comprehensively rather than too simplistically. Thanks.
Thank you very much for that. There is another question in the Q&A from Masvita Rankin, and it's directed towards Tariro. And the question reads, how do you balance the time needed to tailor appropriate messaging with the need to act relatively quickly, since there are lives and health outcomes at stake?
Yeah, thank you. It's a really great question, especially with COVID. I think I earlier used the phrase that we're trying to build the plane as we're flying it, and this is the case. I mean, if you think about it, 3 years ago, none of us knew about COVID. We figured out the sequence, at the beginning of 2020. And in less than a year, we had a vaccine that had emergency use authorization. And this is highly, highly unprecedented. It's a remarkable achievement of science that this has happened, that we have sort of the technical capabilities to develop vaccines so quickly. It's remarkable how we all rallied together, particularly as regulatory authorities, to try and cut the red tape, accelerate where we could without compromising in any safety and any issues. And so we have this remarkable quick development of vaccines. But in the meantime, the virus itself was also evolving. It was spreading through communities, spreading through populations, doing what viruses do, learning the host immunity and evolving and changing its characteristics as well. So there have been multiple moving parts with this virus, as well as the vaccines and the interventions that are available to us. So to put it mildly, I think it's been very challenging for governments, public health folks to tailor messaging, because a message for today may not be relevant tomorrow and may have shifted. So I think what's really important, particularly in this situation, is being very transparent about what we know and what we don't know. It's almost Rumsfeldian to think about known knowns, unknown unknowns, known unknowns, and how do you sort of plan for all of those things. And I think they're being somewhat humble as public health practitioners, scientific leaders, doctors. And relaying to the public, this is what we know now. This is what we think the science may lead us. However, we don't know. I think none of us, have a crystal ball and can predict the routes, for example, of new variants developing, whether or not they'll evade our current vaccines, whether or not we need to change the language around herd immunity, whether or not we need to change the vaccines that we deliver, give boosters, when to give boosters, etc. So being very transparent to the public about what we know now, what we don't know, and some of the things that we might need to address down the pike. But it is a massive challenge, particularly in this case, where you're right in the middle of a storm, the visibility is still not clear. There's so many factors changing the environment. So I think here some humility and transparency in the communication is going to be key in building that long-term trust, so that people know that your intentions and that you're developing policy and framework based on what you know now, with the ability to adapt and change as new information becomes available.
So, but I just wanted to say that is a really, really strong way of ending our conversation today. I mean, the bigger picture is that the world needs to be, in fact, flooded with vaccines, and it's going to take a heavy lift to do that. The production side will gear up by the middle of next year to make that possible. Then it's the question of the distribution, which we know is plagued by inequality, but we have to fight on that front to make sure that in the interest of human survival, that in fact, and human health and advancing and protecting people, that we tackle that fight. And then is the issue that we've been dealing with, which is once those vaccines actually arrive, how do we get it how do we get people to consent to vaccination? And how do we then remove the barriers to that process? So it's really quite important that we do that and keep at it and be persistent. So Janan at the beginning mentioned a project underway that's led by her in the case of South Africa and led by Tariro in the case of Zimbabwe, to get a much better handle on the local information that we need to acquire in order to calibrate those levels of social interventions and dimensions of social interventions on a local level. You notice that the data are often presented as national. So we've got a national picture, a good regional picture, but what we require actually is local information. So all by way of saying, that informs the strategy. For this phase, there are more phases coming. We need to keep doing this. So this is a beginning of an ongoing conversation. In fact, this is in the middle of a series of ongoing conversations, and we will connect up with everybody again at some point in the future. So just to thank Tariro very much, Janan, Jonathan, and Hassan. Also to Harlow, who is the coordinator and introduced today's session. Thank you very much for your efforts. And with that, please enjoy the rest of your afternoon or your evening, depending where you are. With many thanks. The next and final session is tomorrow. Hassan mentioned Helen Rees, who is one of South Africa's leading health scientists in this area. She will be speaking. And the lecture will be given by a Columbia University professor, Wafa El-Saida, who's also well known in the global health world. So that will be our final session. Please join us again tomorrow. Have a good evening. Good afternoon.